Let's start. As the president has said, we are running out of time. Last week, we mainly looked at, no, the last time we met, we mainly introduced chest imaging, where we looked at the imaging modalities and we addressed plain radiography of the chest in a little more detail regarding the techniques and what the qualities of a good chest radiograph would be like. And then we winded up by looking at radiological anatomy of a normal chest radiograph. This morning, we are going to address the other remaining imaging modalities along with other issues that are going to come up. And we are going to start right away with radionuclide imaging or nuclear medicine. It doesn't have a very big role in thoracic imaging currently, but before it was mainly employed in the diagnosis of pulmonary embolus. And when it would be used to diagnose the embolus, there must be a recent chest radiograph along with it. In addition to pulmonary embolus, it's also used to evaluate emphysema and also the extent of other parenchymal lung diseases. Particularly for emphysema, it's useful to the cardiothoracic surgeons when they want to quantify the volumes of the lungs. You know, these patients of emphysema usually continue to have air retention to a point that the thorax is so expanded that at some point the cardiothoracic surgeons may have to go in and reduce on the volumes of the lungs. So we use radionuclide imaging to quantify that lung volume. Lastly, it also has some role in monitoring therapy, and this particularly we are referring to oncology patients. So if a patient already has a diagnosis and is undergoing treatment, we may use radionuclide imaging to monitor response to treatment. Aside from that, there are not many other uses of radionuclide imaging when it comes to the thorax. Let's just try to look exactly what happens when we are trying to assess a patient who is suspected for pulmonary embolus. Usually, this particular scan, some literatures talk about it as the VQ scan, which I guess you could have come across it in your textbooks. So literally what we are referring to is ventilation perfusion scan. And the patient undergo scanning twice. One of the phases of the scan is the perfusion scan. So during perfusion, the patient is given intravenous injection of radionuclide, which is technetium, attached to microspheres of albumin. These microspheres of albumin are designed in such a way that their size will allow them to get trapped in the pulmonary capillary beds. So once it is injected into the patient's circulation, it will move along with the blood until it reaches the pulmonary capillary beds. That is where it gets trapped. Then the radioisotopes begin emitting radiation from there, and the image is taken like what we're seeing right here. Then the second phase of the scan is the ventilation phase. In this phase, the patient is again nebulized with a radioisotope. Again, this time it is going to be technetium, which is attached to carrier molecules. So as a patient breathes in and out during that process of nebulization, the radioisotope settles down in the alveolar spaces. Once it is settled there, they begin to emit this gamma radiation, which is again imaged so that we have ventilation images like we are seeing there. Once we have done that, we go to the phase of interpretation. And during interpretation, what we do is basically to compare the perfusion scan images with the ventilation scan images. If they both look similar, then we say there is matching. The two images match. But if they don't match, for example, in this particular case, we have those filling defects, those cold areas that you're seeing present on the perfusion image, and yet they are not present on the ventilation image. Then we say there is ventilation perfusion mismatch. We say this ventilation perfusion mismatch. And in this case, we are getting these cold areas in the perfusion images because of embolus which are present in the pulmonary vascular networks. It means when we gave our intravenous radioisotope, it was able to reach only areas where the pulmonary vascular network is patent. But where they are blocked by embolus, the radioisotopes were not able to reach there. So once there is a mismatch, then we know our patient is a suspect of pulmonary embolus. That is how it is usually interpreted. Away from that now takes me to computed tomography. This is the modality that falls only second after chest radiography when it comes to evaluating chest pathologies. It's our more or less like the next result, and it tends to solve most of our problems. So it is increasingly being used for examining the chest, the only drawback being the high radiation dose that are associated with it. The newer versions of CT machines enable us to image the patient very fast. For example, just a single breath hold, we are able to acquire all the data sets related to the thorax that we may want. What are some of the indications of computed tomography in the thorax? One of them is staging of lung cancer and other malignant tumors. Secondly, we use it a lot when we are evaluating patients in whom we suspect those diffuse lung diseases, especially the interstitial ones, where we particularly employ a special protocol called the high resolution CT. We also use CT a lot when we are looking at pleural diseases, for example, pleural fluid versus malignant tumor. You know, Sometimes on a plain radiograph, we can't easily differentiate them, but once we use computed tomography, we are able to differentiate the two. Empyema versus lung abscesses. Again, sometimes we have that dilemma when we are looking at plain radiographs. So it's a very useful modality in that area. Disease processes in the mediastinum. So you can think about all those structures within the mediastinum. We assess them right from the heart. We do a lot of coronary angiographies in case we're suspecting ischemic heart disease. We use it a lot to assess those major blood vessels in the mediastinum. Again, think about structures like the esophagus. When we have primary neoplasm of the esophagus, we use it a lot when we have to do staging, plus the many other masses that may present themselves in that compartment, especially related to, for example, the lymph nodes, the thymus gland, which is right in there. The fifth situation is in conditions in which our interpretation is inconclusive following chest radiography. So we may use CT to give us more headway in such situation. And lastly, we use CT a lot when we have to carry out interventional procedures in the thorax, especially taking out biopsies from the lungs. So exhaustive, but those are some of the key indications of computed tomography when it comes to CT of the thorax. When we are looking at these CT, are commonly presented with two sets of images, one of them being a mediastinal window. And when you have to look at it, you really have to look through all the slices. Let me just try to project one and I see if it can work for us. Just hold on a bit. So let me see if I can project another image. So this is just a simple illustration of CT of a patient's thorax. So when we are looking at it, you can see now I have a mediastinal window on one side, and on the side I have my lung window. So I can comfortably scroll through the slices. So on this side, you can see that the lung tissues are clearly illustrated. On this side, you can clearly see that it's mainly the structures in the mediastinum that we are able to see right there. And when you are dealing with this on your software, you can also have a display of your image in a 3D as we have it here. So you have a sagittal section right there. You have your axial image right here and the coronal section right there. So when you have a three-dimensional display as this, things become much easier because you can easily focus onto areas that you want. For example, if we want to focus on this area in the apex on the right, where we have some bit of fibrosis right there, we can clearly look at it in all these planes. So that is what we have for the case of CT presentation. So back to our presentation here. We have already looked at the indications and the sets of images that you may have. In addition to these two, you may also be provided with bone windows, especially if there are problems noted in there. Takes me next to MRI of the chest. And in our opening remark, we are saying the role of MRI is not yet clearly defined when it comes to chest imaging. So when we employ it to evaluate any pathology in the chest, we are only using it to answer some specific questions. For example, we know it is good for blood vessels and lesions within the mediastinum, and basically to answer some specific questions related to that area. One of the reasons why it doesn't have a very clearly defined role is that the respiratory movements and the cardiac motions tend to degrade the quality of the image a lot. And then it's also unable to show us or demonstrate for us the small pulmonary blood vessels and bronchi, as well as lung tissues. So it has some of those limitations. It's unable to provide the same anatomic detail as high resolution computed tomography. So at the end of it all, CT is the procedure of choice for most diseases of the thorax after chest radiography. What about ultrasound scan in the chest? At the moment, there is a lot of research which is going on, trying to assess what ultrasound scan has to offer when it comes to the chest. It's being, there's a lot going on in the children, trying to see if we can adequately use it to diagnose things like pneumonia in children. And it's becoming a mainstay, especially in emergency units. Some of you have already heard about point of care ultrasound scan. So it's being used a lot in emergency units now to pick out some pathologies that physical examination would not adequately reveal. There are challenges that have made it not to develop roots in some of these areas fast enough. One of them is the acoustic mismatch between the chest wall and the aerated lungs. When we did the introductory sessions, we said gaseous medium is a big limitation when it comes to ultrasound scan. usage. So that is what we encounter when it comes to the thorax. So in other words, what we're saying, we are only able to visualize what is happening within the chest wall and the pleural space. And beyond that, we can't see anything when the lungs are aerated. Ultrasound scan is of little use for lung pathologies, except for diagnosis and localization of effusions or other collections within the pleural space, as well as chest wall pathologies. For the case of pleural fluid, it will appear as an echo-free area outlining the pleural space, echo-free or anechoic area. We use the word echo-free with the anechoic synonymously, so you have to be flexible there. Echoes in that fluid. So if that fluid we are seeing is no longer anechoic, but it has some debris in, then our interpretation will switch to either what we have there being blood or pus. So this will depend on the patient's presentation. If it is, for example, a trauma patient who has presented, then chances are high that it is blood. But if it is not a trauma patient or a patient who has presented with pruritic pain along with maybe other constitutional symptoms related to an ongoing inflammatory process, then we think more along the line of pus. And this becomes even more clearer if we begin to see septations within that area of fluid collection, along with thickening of the pleural lining. Ultrasound scan also helps us to look at pleural-based masses, and these pleural-based masses, we can easily characterize what they are along with, as we do this ultrasound scan. And of course, with all these that we have mentioned, we can also do interventional procedures with ultrasound guidance. For example, if we have identified that there is fluid or there is pus or blood, under guidance of ultrasound scan, we can put in a drainage tube to evacuate that fluid. Some of you later on will go to work in different centers. You'll go to some centers where their protocol dictates that you cannot put a drainage tube, for example, into somebody's thorax as a blind procedure. There has to be image guidance, either under fluoroscopy or ultrasound scan as this, because there are medical legal issues that you can easily get embroiled in if you do such a procedure blindly. And it happens. Many times patients are sent to imaging even right here. When you do imaging, you find that somebody has put the tube past the pleural space. The tube is into the lung tissues. There are times when you find the tube is actually almost perforating into the heart. That is the importance of doing such a procedure and imaging guidance. If they're solid masses, with the aid of ultrasound scan, and we know that they are either on the chest wall or in the pleural space, we can easily take biopsies under its guidance. So that is what we have regarding the other remaining imaging modalities. I would like to welcome your questions, if at all there is any, before we go into this next session. Do we have any questions so far? Any questions so far? You can unmute and ask your question. Yes, Jonathan?
Yes, thank you, Doctor. So I have just two questions in relation to the imaging modalities. So talking about the CT scan, I was wondering whether our unit here, does it have a high resolution CT or a spiral CT? That is my first question. Then the other question,
spiral, yes.
the other question is in relation to the ultrasound imaging. So do we consider it as echo as part of ultrasound, since it also uses literally an ultrasound machine, or that is very, very different? If you're doing
consider
echo as part of image.
Okay. All right. Thank you, Jonathan. Tony, let me answer Jonathan, then I get back to you. His first question relates to CT, and he's asking about high resolution CT and then the spiral CT. So when you talk about high resolution CT, it's just a protocol. It's just one method of scanning the thorax, which is actually present in that CT scan. For example, the one we have here in the hospital. It's just like having your computer with many softwares that you can use at whatever time it's required. So it's present in most of the CT scans, right from, I think, even a two-slice scanner. That is a very low generation CT scan, but it's present. So it depends on your request. If you as a clinician has requested that the patient you have would benefit from a high resolution CT scan, then it is up to us to just command the machine to scan the patient in using a high resolution CT scan protocol. Then the spiral scans. CT can scan a patient in two ways. One of them, this spiral and whatever depends on, is used to describe the movement of the X-ray tube and the examination table. So those movements can be categorized into two. One of them is sequential, and then the other one is spiral. So when we talk about spiral, it means
even if I'm not attending, but when it's dropped in, they know that I'm attending. They can know that you're attending. Yeah, they know that I'm attending.
So you can see what Alex is up to just by showing himself, and he's doing other things, and he's very happy about that. So when it is a spiral, we mean the X-ray tube continues rotating through that 360 degrees, while the table also moves constantly through that opening on the gantry. So it keeps moving constantly as the tube rotates around the patient. That is what we mean by a spiral. Then when we talk about sequential, it means the tube makes a 360-degree turn, then the table moves one step. Then again, another 360, the table moves another one step, like that. That is what we mean by spiral and sequential. Then ultrasound scan and echo. So echocardiography is just one method of ultrasound scan. specifically used to scan the heart. So it's straightforward. It is still an ultrasound scan technique. Who had a question? Tony? Tony, you can.
Thank you, Doctor.
Yes.
So I did how the ventilation scan comes to get the wedge-shaped abnormalities you talked about. And if they are present, what does it mean? Because ventilation is not about perfusion. Thank you.
Ventilation is not? I beg your pardon there?
Okay, I thought the
oh my God, the
abnormalities come in.
So when we were talking about explaining ventilation perfusion scans or the VQ scans, we explained that the patient is scanned twice. The first phase, when we're acquiring perfusion images, and we said during that phase, the patient is injected with intravenous radionuclide or radioisotope, which is attached to albumin. Albumin spheres, and we said those albumin spheres are there with the expectation that their size will allow them to get trapped in the pulmonary capillary bed. So think about how that pulmonary artery moves and branches into the lung tissue until it reaches the capillary networks before it transitions into the venous network. So it's going to get trapped in the pulmonary capillary bed. But once you have visualized that, think about this patient who has presented with embolus. So this embolus has already blocked some of the pulmonary artery networks. Okay, so it means once you have injected this radioisotope, it means your radioisotope will only be able to reach the capillary networks where the pulmonary arteries are patent. But where they are blocked, it will not reach, such that when you take the perfusion images, they are going to be hot and cold areas. Cold areas, or those areas with the defects or wedge-shaped defects, are areas where the pulmonary artery to that area is blocked. Okay? Areas where the radioisotope has reached, it means it is not blocked. The second scan is done as a ventilation phase. So we nebulize the patient with the radioisotope. So it's just like how you do nebulize asthmatic patients in the ward. And the expectation this time is that the radioisotope is going to settle down in the alveolar spaces. And once it has settled there, we again take images of the lungs. So we compare the two images. We compare the perfusion images with the ventilation images and see if they look similar or not. If there is presence of embolus, then we expect that they are not going to look similar. There's going to be a mismatch because they are going to be cold areas or defects on the perfusion images which are not present on the ventilation images. I don't know if that makes sense now. Tony, are you there?
Yes, doctor. I think I understand now.
Okay. Do we have any other?
Yes, doctor.
Yes.
What is the use of the mediastinal window and lung window?
What is the? Okay.
This is significancy.
Okay, mediastinal window and lung window. So just like the name suggests, when you're looking at the mediastinal window, literally what we're saying is that you've commanded your computer to show you clearly the structures within the mediastinum. And when you're looking at the lung window, it means you have instructed your computer to show you clearly the lung tissues. Okay, these two structures within the mediastinum and those within the lungs, you cannot see both of them adequately or optimally in only one window because of the difference in their contrast. That is why you have those two windows. And I think I tried to project to you what a mediastinal window was and what a lung window was. You could easily notice the difference that when I was projecting the lung window, you could only see the lung parenchyma with those vascular networks within the lungs, but you couldn't see anything within the mediastinum because it was all white. You couldn't see anything on the chest wall because it was all white. But then when I again projected to you the mediastinal window, you could easily see all those vessels, the aorta, the pulmonary trunk, the heart and its chambers. You can even see the esophagus. But in that window, you could not see the lungs. The lungs were all looking just black, uniformly black. No other detail that you could pick out from there. That is what they are, and the significance is basically to help you appreciate those two compartments better. Okay. Can we go on? Okay, if there are no more questions, then we can get ourselves focused to something else. So we are going to start addressing thoracic abnormalities. And as usual, we shall start approaching it first in general terms before we can narrow down to more specific things. So let's see how we can easily make our lives easy by trying to make some arbitrary categorization. We can address the lungs the thorax in different, as having different compartments. So you can think about the thoracic cage and its soft tissues as one compartment. Then again, you can think about the lungs as one big compartment. You can think about the pleura as one compartment of its own. Another one, you can think about the heart and the other mediastinal structures as independent compartment, then the hilar areas and the diaphragm. All this is just to make life a little easier, because on the face of it, we already know that some diseases will affect only one or two of those areas. So we can easily come out with a reasonable list of differential diagnoses when it comes to a real clinical situation. So that is the simplest way we can easily think about it. Another person can even try to categorize it differently, as long as it makes life relatively easier. When we pick out just the thoracic cage and the soft tissues, a number of things can go wrong in that area. For example, somebody may just present with lumps in the breast or other soft tissue masses in the thorax, on the chest wall. And for now, the only thing I'm cautioning you about is that these masses can easily be mistaken for pulmonary masses, especially when you are dealing with chest radiographs, because chest radiographs are projection images. So things are superimposed on each other. We may still have many other things going on. For example, structures superimposed on each other can also mimic lung disease. For example, an area where the scapula is lying and there is also a rib traversing the same area. So it can mimic a disease process which is going on in the lungs when actually there is nothing. Others can be inanimate objects that are on the patient, for example, the buttons or other fasteners, or even folds from the patient's clothing if it is not, if the patient is not adequately exposed. So we have to think about those ones and not to get into traps with them. What is most important is that we shouldn't assume that they are, or assume and just disregard them like that. You can always confirm this by re-imaging the patient after removing structure, clothing or whatever from that area. Sometimes you may also choose to take another projection or another view which is at right angle to the previous one, so that you're able to form that three-dimensional outlay, and you now get to know exactly where whatever you are seeing lies. Rib fractures and deposits, they may also be present. You don't need to forget about them. And these ones may show us peripheral opacities related to the ribs. So I'm just trying to open your mind that there are a number of disease conditions that may only affect the chest wall and the rib cage, and that we should be able to pick them out. Secondly is that there are also other mimics and inanimate objects that may appear on our images related to this chest wall and the thoracic cage that may affect our interpretation. And how we can easily address it is to re-image the patient after adequate exposure, or we take another projection of the same area at right angle to the previous image. Away from that, let's think about the lung as a big compartment. Yes, reflect back on the lung from your gross anatomy, how it is built up from those small components up to what it is. We can easily appreciate or imagine the lung to be having fine networks of air spaces, which are predominantly the alveolar spaces, and then supporting those air spaces or the alveolar spaces is the interstitium, where we have the blood vessels and the other lymphatic networks and the connective tissues lying. So that is our simple imagination of what the lungs are made of. So diseases that affect the lungs may affect either the alveolar spaces or those air spaces that we have pointed out, or may affect the interstitium or that area where we have the supporting connective tissue networks along with the vasculatures. And again, some diseases might affect both areas, the interstitium and the alveoli. But once we have tried to break it down as we have done, you can see that, again, it can help us to narrow down on our list of different possible differential causes, and we, at the end of it all, we're able to make a diagnosis. It's important for us to do that, but it is very difficult. Again, when we are presented with images of the lungs, one big conclusion that we can draw out is that there are diseases that will result in lung opacities or shadowing. So it will transform the lungs from looking black to looking white. Then there are also those disease processes that will transform the lungs from looking at least black to transforming it to look even much blacker, if at all that word exists. So that is how we can easily think about it again, that there are those that will result in opacities, or there are those that will increase the blackness of the lung tissues. For this particular session, we are going to focus ourselves here on those ones that will result into opacities, lung opacities. So let's go down to these two important signs that help us to understand whether the opacity we are looking at is in the airspace or is in the interstitium. Yeah, it helps to some good extent, but not always the case. So these two signs are listed down here. That is silhouette sign and air bronchogram. We're going to look at some images to help us drive it home. We have two chest radiographs. One of them is we're going to use it to illustrate a silhouette sign, and the other one we shall use it to illustrate air bronchograms. So let's reflect back, or you bring back the mental image of a normal chest radiograph that we talked about the last time we met. One of the key things we pointed out was that the outline of the mediastinum should appear clear or should look clear. That boundary between the mediastinum and the lung tissues must be clear. It should look clear. Similarly, the boundary between the diaphragm or the dome of the diaphragm and the lungs should also be clear. Just like how you can trace it here. This boundary is very clear for us. Similarly, on the left, very clear to us. And then we also, during radiographic anatomy, we clearly said that the lung parenchyma should be of equal transradiance. So the left should be equally black or dark as the right. But look here, what is happening? We have an opacity there. So there is an area which is looking white within the lung parenchyma right there. And the second thing, let's look here. We cannot trace the boundary here, the boundary between the lung and the right heart border. That boundary is indistinct or it is lost. So what I'm trying to explain here is that that loss of boundary is what we are referring to as the silhouette sign. Okay. The silhouette sign is now present because the contrasts of this lung opacity is similar to the contrasts of the structures within the mediastinum. So there is a silhouette sign. This opacity has a silhouette sign with the right heart border, as we can see there. Turning to this other image on the right, yes, of course, you can already appreciate that. Again, there is an opacity this time in the upper zone. Before, it was in the mid zone on the right, but this time it is on the right upper zone. We can clearly see that it also has a silhouette sign with the superior mediastinal border on the right. But I want you to look deep within this area of opacity. Do you see that there are some black tubular structures or features within that area of opacity? Some black tubular structures or features, and you can see that as they move towards the peripheries of the lungs, they are also tapering. That is what we are referring to as air bronchograms. Air bronchograms. So these two features that we have talked about, or these two signs that we have mentioned, the silhouette sign and the air bronchograms, those two signs are only present when the disease process affects the air space. They're only present when the disease process affects the air space. We don't see it when the disease process affects the interstitium. Okay, so you need to get that very clearly. If it is not clear, you better ask now before we leave for some other things. Okay, I think that is clear. Now we are. Yes, Mercy?
I beg your pardon on the other sign, not the silhouette.
The air bronchograms?
Yes.
So I only asked you to look keenly within this area of opacity. If you're keen enough, you should be able to see that there are some dark tubes or black tubular structures which are projecting into that area of opacity, and that is what we are calling the air bronchograms. I am going to try to explain how it comes about in the subsequent presentations, or slides. Okay. This outline that we're seeing here, which is very clear now, that outline is demarcating for us the horizontal or the minor fissure. So we have this opacity in the right upper zone having a silhouette sign with the superior mediastinal border on the right, and it is limited inferiorly by the horizontal or the minor fissure. Within this area of opacity, we can appreciate air bronchograms. So let's try to see. This is just a magnification of the similar things I'm trying to ask you to be able to see right there. This is, yes, please.
Yes, I have a question. So when someone says there's an obliteration of the silhouette, is that the same thing that, would that mean the same thing as a silhouette sign, or that is very different?
Yeah, it is similar, because if we look at what a silhouette is just a boundary. It's a French word, I think, that refers to a boundary. So if there is obliteration of a boundary or a silhouette, I think that is clear. The only thing that, or the common mistake that we tend to make is when we talk about a positive silhouette sign, and that means definitely there has to be a negative silhouette sign. So it doesn't really make sense. So for us in radiology, we restrict ourselves to just a silhouette sign. If there is loss, or if I borrow your word as obliteration of a boundary, we clearly talk about a silhouette sign. There's a hand up from Kintu. Yes, Kintu?
Yes, I want to ask what exactly causes the silhouette sign in airspace disease and not in interstitial disease, if I got you right?
What exactly causes the silhouette sign? If you remember, okay, I think maybe you reserve your question. If the next few slides don't answer, then we shall get back to that. Let me also just put it somewhere. So aside from that, this image that, or this drawings that sometimes confuses a little is what I want us to look at. This one on the left. You can ignore the one on the right for now. So we have said that we see silhouette sign and air bronchograms when there is a disease process going on in the airspace or the alveolar spaces. So just think about these areas shaded black as areas which are occupied by alveolar spaces. Okay, and then this tubular structure that you're seeing here are representing the bronchi or the bronchioles for that matter. So if, let's say there's a fluid accumulating in the alveolar spaces, there is fluid present in the alveolar spaces. We said from our introductory remarks that the radiographic density of fluid is what? Is gray, isn't it? Isn't that what we say? We said the radiographic density of fluid is gray. We say the radiographic density of soft tissue is gray. So it means all these areas on our radiograph is going to look or is going to appear gray. But what else is going on? The other thing is that is going on is that this fluid is not yet large enough to also begin collecting in the bronchi and the bronchioles. So it means the bronchi and the bronchioles are still containing air. Okay, so it means on our image, this white tube here is the one which is looking black, and then these alveolar spaces here, because there's already fluid in, or any other soft tissue, is already looking gray. So let's get back to the other image. So we are saying the alveolar spaces are all filled up with, for example, some fluid, and it is gray. And within the same area, the bronchi and the bronchioles still have hair in them. So air casts a black shadow, and we can still see it as dark as we're seeing there. That is why we are referring to as air bronchograms. Air in the bronchial or spaces in an area of opacity. I hope that now explains to somebody who asked about the air bronchograms, what it is. Similarly, for Mr. Kintu, who asked about silhouette sign. When we were doing the introductory session, we made a definition of some terms. And when we were particularly addressing the area of characteristics of an image, we defined one of them as being contrast. Contrast as a characteristic of an image. And we said, we define contrast by simply saying that we are able to see two structures or two features as different because they have what? Different contrasts, or because they appear different. Or they have different degrees of opacities. Let me use that word. But the moment you put two structures together and they have similar degrees of opacities, it means there is no contrast between them and you won't be able to see the boundary between them. So what we are looking at here, the contrast here, this is gray, and the contrast within the mediastinum here is gray. So you cannot appreciate that there is a boundary here. we can only appreciate it right here because this area is black, this one is gray, and there's that clear boundary. I hope I have tried to answer your question, Mr. Kinto. Mr. Kinto, have I answered your question?
I'm just wondering what is special about airway disease, because because I would think that interstitial disease would also bring about the silhouette sign, because it's going to create a loss of contrast between the mediastinum and lung tissue. But I'm just wondering why.
Yeah, and surprisingly, it doesn't. Probably I may have to look at a better explanation to that and give you at a later time. Let me listen to Aggie. Aggie, please ask your question. Okay, she's not on. So let's move on a little more and see if maybe my other explanations will suffice. So let's look at alveolar or airspace opacities. We are now just going to try to describe the whole process. And we're saying that if the alveoli are involved in a disease process, things like fluid or solid tissue may fill that space. And in the very early stages, it may be that the alveoli show as small, separate, round opacities of that dimension. So it means in an area where there is a disease process in the airspace starting or alveolar space starting, what happens is that we begin to see some small round opacities in that area, but as this disease process progresses, these small opacities rapidly become confluent. They begin joining up. As they become confluent, we begin to see a larger opacity with which looks fluffy or feathery with ill-defined margins. So it becomes larger, feathery with ill-defined margins. As that process progresses, the vessels or the vascular markings that you saw in the normal lungs become obscured. And at this same stage, we may begin to see or appreciate air bronchograms. But as it continues, we also begin to see silhouette signs. So loss of demarcation with the other structures looking similar to it. And when the alveolar space fills with fluid or other substances, and then we begin to see bronchograms along with the silhouette sign, that is when we begin referring to as a consolidation. We begin referring to it as a consolidation. So it's a whole process that we start from those small round opacities that become confluent and feathery. At some point, you begin talking about ground glass opacities. As it goes on, it becomes much denser that it obscures even the blood vessels, air bronchograms become apparent, there is a silhouette sign apparent, and we outright begin talking about a consolidation within the lung. This is still describing more or less the same thing that we have already talked about. So if we look a little deeper into disease processes in the air space or the alveolar space, those opacities, we can identify some patterns. And there are about 2 or 3 patterns which are easily identifiable. One of them is the segmental or the lobar pattern. The other one is the bat swing pattern. The third one is the one which is neither segmental nor bat swing in appearance. We are bringing up this still to further help us narrow down on our differentials at a later date. For example, we are already saying here outright that bat swing pattern typically in pulmonary edema. That is the commonest clinical scenario that where we shall see bat swing pattern of alveolar shadowing or airspace shadowing. The other one we said it is segmental or lobar. Segmental or lobar because we're saying that it conforms to the shape of a lung lobe or it conforms to the shape of a lung segment. So if you remember, the lung has got lobes, and then within the lobes there are segments. So it conforms to one of those. And in both bat swing or segmental, we may still have air bronchograms visible. Here we are with the 2 radiographs. One of them is illustrating bat swing, but I'll push ourselves to the next slide to make the point home. And then this one is a lobar pattern. So it is confined to a lobe. Let's first look at this image here. So I think this can supplement your imagination of what we are referring to as bat swing. We're basically saying that the opacities are bilateral and it starts from the hilar areas and spreads out into the rest of the lungs. Just like how you see this mammal has spread out its wings, and the origin of the wings corresponding to the hilar areas, and then it spreads out as that. So if we go back to this first image, it is giving us a similar impression that we have bilateral opacities in these lungs, but it appears to have started from the hilar areas and spread out into the rest of the lungs. But of course, you can still see that there's still spared the costophrenic recesses as well as the apical areas. And on the other side, it is typically what conforms to a lung lobe, and it still has those other features that we've talked about, silhouette sign and the air bronchograms. So takes us now to what were we referring to as can easily fill up the air spaces. What sort of fluids can we have, or what sort of pathological processes can happen within that airspace? So one, we talked about fluids, and we can categorize the fluids that can accumulate there. That can be a transudate. And for example, in case we are confronted with patients with these major organ failures, the heart, the liver, the kidneys, we expect such a situation to arise, that fluids can easily accumulate within the airspace or alveolar spaces, and gives us typically feature of pulmonary edema is the best example of a transudate. In other situations, it can be an exudate. So think about that patient who has just who has caught a pneumonia. So these organisms have settled down in the alveolar spaces. It has triggered the immune response, and one feature of such immune response is accumulation of what? Exudate fluids in the alveolar spaces. So it will fill up most of those spaces until it gives you what you later on begin saying, oh, the patient has maybe a lobar pneumonia or something of the sort. If it is not an infection, it can happen in situations of, for example, respiratory distress syndrome, pulmonary eosinophilia, and this alveolar proteinosis. That is another form of fluid that can accumulate in that space. Thirdly, it can be blood collecting in the alveolar spaces. And this can be in situations of trauma to the chest, as we are referring to here as contusion, or it can even happen in patients with bleeding disorders as a result of maybe our own interventions, because we have overprescribed our drugs, or those warfarins and the heparins, or because the patient has a hemorrhagic kind of disease. Away from fluids, that space can also get filled with things which are not really fluid. For example, if that space is infiltrated by tumor cells, so it is filling up with solid tissue, as may happen with lymphoma or other kind of neoplastic situations. Then we also have these other miscellaneous situations, leakage of gastric contents into that area, aspirations, foreign bodies or foreign materials. All those can result in opacification of those spaces. But as we wind up that, these are some of the common causes of airspace shadowing: infections, pulmonary infarcts, tumors, and lung contusion in case of trauma. These are the ones that you may get confronted with them much early in your clinical practice. So it kind of summarizes what you're likely to encounter. We still have more images. So again, you can clearly appreciate that this is airspace, opacity, and what pattern are we seeing? We are seeing a pattern which is lobar in nature. So we can see that it has some silhouette sign with that right at border, but for now it is still faint. We don't easily appreciate the air bronchograms, but of course there's just one which I can easily point out there. This is on our PA projection. We can clearly see that the outline of the right hemidiaphragm is very clearly outlined, and there's a reason for that. When we look at it on the lateral radiograph, you can now appreciate that what we have is a triangular opacity, which is limited above by our minor or the horizontal fissure, and limited on the lower aspect by the major fissure. It has the apex, which is pointing towards the mediastinum there. So it's showing us classically that this is a middle lobe consolidation that we are looking at. So that is another example for you. What about the bat's wing? When do we most likely see it? If the presentation is acute, we commonly see it in cases of pulmonary edema. But once it is chronic, then our list of differentials become longer. Along with this, maybe I can put also PJP among the acute presentation. That is, of course, if you're presented with a patient who is immunosuppressed and at the same time has got AIDS. So what I'm saying is that if you're presented with a patient with severe immunosuppression with bat's wing, you should also have PJP as a differential there. What about in the chronic variety? We are already having things like lymphoma or leukemia, cases of sarcoidosis, although we see commonly the interstitial form, PAP or pulmonary alveolar proteinosis, and alveolar cell carcinoma. Although this alveolar cell carcinoma tends to give us what? It tends to give us the lobar or the segmental pattern. Yes, Joseph? Joseph, go on and ask your question.
Thank you. I would like to have more clarification on the pulmonary alveolar proteinosis. What is it really?
Where is?
Like, what is pulmonary alveolar proteinosis? What does it stand for? What does it mean?
I think now that one I'm going to push you back to your pathology lecturer, because you should have cleared up that at that point. But for me, I'm now addressing pulmonary alveolar proteinosis and radiology, and basically as a pattern, but pathology doesn't miss out on that. So if you missed out that, just flip back through your pathology literature and you come back home and dry. This, I think we have already looked at it, the bat's wing and how you can easily have that mental image. This is another supplement of that patient with this bat's wing, and along with that, you can see that degree of cardiomegaly. So probably giving us already the source of the pulmonary edema. What about the other third pattern that we talked about, that It's neither bad swing nor segmental or lobar. One of them is bronchopneumonia. So bronchopneumonia is the air space or alveolar space disease, which basically will result in patchy opacity. So we have patches of opacities either within a lobe or diffusely throughout the lungs, but they don't become confluent. That is why we are using the word patchy. They don't become confluent. So meaning in between those opacities, there are areas of normal lung tissue or normal lung aeration, along with right here, we have some of the common infectious causes, staph septicemia being one very common cause, as well as pulmonary tuberculosis. Still in this same category, we also have this issue of fat embolism. And for the case of fat embolism, it tends to appear as it's usually like a miliary kind of appearance. So if you've ever seen radiographs of patients with miliary tuberculosis, this fat embolism looks very, very similar. And we can only make this interpretation in the background of a patient who has sustained fractures to the major bones, or one who has undergone a major orthopedic procedure. They're the ones who are likely to be candidates for this fat embolism. The third example in this category is also eosinophilic pneumonia, or what sometimes we refer to as low-flash pneumonia. With this, it tends to have a different pattern. Its pattern is in such a way that we have these opacities or these airspace opacities starting from the peripheries of the lungs and then moves towards the hyaline. So it's more of like a reverse bat swing, and some literatures will talk about it as a reversed bat swing pattern. And this same pattern that I've described is what we see very often in this new disease, the COVID-19. We also have those alveolar opacities at the peripheries of the lungs. If you guys have already been to the wards before, you could have seen some of those patients with CT or chest radiographs, and you can easily see those opacities lined up on the peripheries of the lung tissues. This is illustrating as some of those where we have those patchy opacities. This time it is bilateral. Along with it, we can see those many areas of normal lung aeration. This is an illustration of fat embolism. Like I told you, it's more or less, it looks like a miliary pattern as we usually see in tuberculosis. So I think I'm going to stop here. When we meet next, we look at these interstitial shadows. John Robert.
Yes,
Robert.
Doctor, good morning.
Good morning.
My question is about this fat embolism.
Right.
I'm trying to understand how a fat embolus gets displaced into the
What happens is that those patients end up developing what is more of ARDS. There is accumulation of some proteinaceous exudates in the air spaces. That is how it ends up falling into that group. Yes. There was a second. Yeah, there was a second person. Yes, go ahead, Jonathan.
Okay. Yes. Thank you so much, Doctor. So my question, I have questions. Once in relation to P, well, commonly known the wage
your network is your network is breaking a lot.
I was saying in relation to the problem. I don't know. Can you be able to hear me?
Okay, it's better.
Okay, yes. I was saying in relation to pulmonary embolism, the wage sign is how often is it easy to see that kind of description or an image of that kind of pulmonary embolism? That would be my first question.
Okay.
Then still in
How
relation
often?
to the yes, how often do you see that? Then still in relation to the the COVID-19. I've seen some CT scans of patients who have, let's say, the ground glass appearance that is on CT scan, which is well detailed. And then you may not necessarily be able to see it, of course, on X-ray. I see sometimes patients who have that typical ground glass appearance on CT scan, whether it's contrast or non-contrast, and you may not necessarily be able to see it as typical on an X-ray. And my question is, why could it be so?
Okay. Why could it be so? So the first question relates to these plural-based triangular opacities. Often we don't see it often. If you happen to see it, then you have chanced on a classical patient. So that is the one strange thing with the radiology. Yes, a typical one is going to be these triangular plural-based. But in real situations, majority of the patients, you're going to see plural-based opacities, which are not typically going to be triangular. So you have to take caution with that. It takes experience to actually be able to understand and also to be able to pick them. Ground glass, typical on CT. Yes, when we image these patients with a CT, we use the high resolution CT protocol. So that protocol is specially designed to show us those diffuse lung parenchymal disease processes. So the resolution is way superior to that of plain radiography. And also remember, when you're dealing with CT images, there is no superimposition of structures, but when you're dealing with plain chest radiograph, there is superimposition of structures. So it will be difficult for you as somebody in training to actually right away classify the kind of opacity that you're seeing, that it is predominantly plural-based or not, but with the time, it is actually possible. So the biggest difference is in the resolving capacities of these two modalities, CT being superior to plain radiography. I think that answers your question. Do we still have any more? If there are no other questions, I think we are going to close our session for today until we meet again next week. Okay. So you're free if you want to leave the meeting room. Just trying to check through the charts if there are any questions which are not answered there, which I think there's, yeah.
Yes, I just wanted to remind you that we are back at campus, and there's a group that will be rotating on radiology starting Monday.
Monday.
Yes.
Okay. So those who will come, at least come with a clear objective of what you want to achieve, so that it becomes easier to get you at least sorted out with that. Otherwise, we don't want to dictate on you what you should really do there. Okay.
Not a doctor.
While you're there, pardon? While you're there are many SHOs in the department. Feel free to interact with them. Emmanuel, go on. Emmanuel? Miro Emmanuel?
Yeah. Yes, Doctor, thank you for the lecture and the presentation. So my question is about CT of the chest. Is there a role of contrast when you're trying to differentiate the different pathologies?
Yes. Contrast plays a big role when we are differentiating those many structures, because naturally some structures don't have very good contrast from the other neighboring structures. It is only until we have given additional contrasts in the form of those radiographic contrast agents, that is when they become easily visualized. I can easily answer it as that. Then, of course, when it is real pathologies, their behavior, how they take up this contrast also differ. Others will take it avidly, others will take it moderately, others will not take it up at all. So that also helps us when it comes to getting our differential diagnosis. I'm just going to try to project for you. No, I think it is, that image is not there. I wanted to give you an image of a non-contrast chest CT and contrast chest CT. But since the president has already said you'll be rotating in the department, we shall be happy to show you such situations so that it's better in a practical setting. Thank you. Godfrey? Godfrey? Godfrey?
Thank you, Doctor.
Godfrey?
Yes, sir. Thank you, Doctor. Thank you for the lecture. My question is, on this last radiograph we have presented, the last two, the left one I see, am I wrong if I say it appears like metastasis in the lungs, and then it appears like diffuse alveolar wound pneumonia? How would you differentiate? Because these last two slides, these last two radiographs you have displayed, this left one, would I be wrong if I say it is a lung metastasis? The way thank you.
Yes, thank you, Bwire. You know, when we interpret some of these images, we take into consideration the clinical history as well. So what you have said is absolutely right, that it can also pass for metastasis. But that would be in one clinical situation, but in another one, it will pass for what we are looking at as just a bronchopneumonia, because maybe in this patient, we have somebody who was typically well before, and all of a sudden presents acutely with constitutional symptoms of an inflammatory process, which is ongoing in the form of fever, malaise, and the rest. And it leaves us with more room to pronounce it as just patchy consolidations that we are seeing. But of course, if the situation was a tumor, a patient with a non-malignancy in one area of the body and presents with such a kind of a chest radiograph with the chest symptoms that have been there for a longer duration of time, or some of them actually, you might take a radiograph of the chest as this, and the patient tells you, I have no problem with my chest. And you see now how you are integrating the clinical presentation into the image. So at the end of it all, without any clinical history, you are 100% right to consider that among your differential diagnosis. I hope that is.
Because yes, my concept when we are doing vivas, you kind of flash radiographs to us to interpret without a prior history. So it becomes very challenging.
That is in the clinical wards where we don't usually get consulted when they're doing such, but if we were being consulted, definitely would ask them to attach a brief history, because it is necessary, unless it is unless there are those disease situations where we know the diagnosis is definite. Okay, that is when we clearly ask for a spot diagnosis. In that case, we don't even want differential diagnosis. We want only one diagnosis. But if that is what they're doing, it's not really fair.
Yes, Dr. Moses, I had an inquiry.
Yeah.
Yes, one of the patients treated for COVID had a bad CT scan, and I was only requesting if I could share my screen just to, okay, it can be looked at.
I hope you'll be able to, because sometimes these hosting restrictions might restrict you from sharing your screen. You can try. Yeah, exactly. I'm going to stop mine. You can try and share your screen and I see if it comes. Does it? Are you able to share the screen?
Doctor, me, I thought sharing would be possible with a co-host. Is it possible for Jonathan to share directly?
I don't know. That is what I was also wondering.
That is what I was also wondering.
Anyway, if it is not possible, I'm going to be.
If it is not possible, I'm going to be
in the CT scan room. You'll get me there.
The CT scan room. You'll get me there.
Okay, please.
Mm.
Mm.